Hello everyone, this is Dr. Madhusudan Rao. In the program I teach medical students. Today my lesson I'm going to touch on hydrocephalus. What is hydrocephalus? It's a condition of excessive accumulation of cerebrospinal fluid in ventricular system. There is a symptomatic accumulation of cerebrospinal fluid inside the ventricles. It could be non-communicating or communicating. It is also described as obstructive, communicative, hypersecretory, or normal pressure hydrocephalus. Like this, there are 4 categories of the hydrocephalus that have been described. Well, it could be congenital that presents in infants and children, or it may manifest at any age depending upon the cause. Untreated may lead to cognitive impairment and physical handicaps, death. Usually treated by ventricular peritoneal ventricular atrial shunts, sometimes ventriculostomy or endoscopic cauterization of the choroid plexus. Acute hydrocephalus is fatal unless treated results in death. Well, cerebrospinal fluid is the dynamic fluid that circulates continuously from the place where it is produced in the choroid plexus of the lateral ventricles and flows through the ventricular system, ultimately absorbed into the dural sinuses to enter into the bloodstream. The details of the CSF production and its circulation will be dealt, and the various causes and the pathophysiology of the categories of the hydrocephalus and the clinical presentation of these varieties will be touched in detail, and a brief discussion on the treatment and the prognosis or the contents of this lesson. Coming to the etiology, there have been 4 categories that have been described besides normal pressure hydrocephalus. One, non-communicating or obstructive, wherein there is a block in the flow of the CSF in its pathway from the site where it is produced to its absorption of the dural sinuses. So non-communicative means there is no communication between the ventricular system due to the obstruction to the flow of CSF. It could be tumors like the papillomas of choroid plexus may cause obstruction to the foramen, that is, through which the CSF exit to enter the other ventricular system. So papillomas of the lateral ventricle may block the foramen of Monroe, through which lateral ventricles communicate with the third ventricle, thereby resulting in the obstruction to the flow of CSF from the lateral ventricle where it is produced, and that results in the backward accumulation of the fluid, resulting in hydrocephalus. The next one is the aqueductal stenosis. It could be genetic in terms of autosomal recessive inheritance, or it could be post-inflammatory, resulting in the scarring of the aqueduct that results in the obstruction to the flow of CSF. Sometimes aqueductal stenosis could be the effect of hydrocephalus, okay, or tumors of the posterior cranial fossa can cause pressure over the aqueductal sylvius, thereby causing obstruction to the flow of CSF from the third ventricle to the fourth ventricle. Well, vein of Galen compressing the causing compression to the flow of CSF. As I told you, post-inflammatory cause causing the obstruction to the flow of CSF at the level of aqueduct of Sylvius. Or it may cause the blocking of the foramina at various levels. Then coming to the communicative. The commonest cause of communicative hydrocephalus is the intraventricular hemorrhage, subarachnoid hemorrhage, or meningitis. Here in all these situations, there is the increased volume of the fluid in the ventricular system because of the either hemorrhage or meningitis, or there is density or hyperviscosity of this fluid secondary to the excessive presence of the macromolecules, which again results in the increased volume of the fluid secondary to the osmotic effect, thereby resulting in the raised intracranial tension. Sometimes it could result in the acute hydrocephalus, which is fatal unless otherwise treated. Okay. Intraventricular hemorrhage, more so common in the premature infants, and also common in the rupture of aneurysms. Then hypersecretory hydrocephalus. This is secondary to the tumors, that is papilloma of the choroid plexus, which results in the excessive secretion of macromolecules into the ventricular fluid, thereby causing the increased volume of the CSF due to oncotic osmotic effect. Normal pressure hydrocephalus. This is common in elderly people. Cause is not known, but there is increased volume of the CSF in the ventricular system. Genetic syndrome, like Dandy-Walker and Arnold-Chiari. Dandy-Walker causes the obstruction to the flow of CSF through foramen mesendae. Arnold-Chiari causes the compression over the foramen lusca, thereby causing obstruction to CSF flow. Well, coming to a brief note on the pathophysiology, where the CSF is produced and how it is circulated through the ventricular system and ultimately absorbed into the subarachnoid granulations, thereby entering into the venous sinuses. CSF is normally formed in the choroid plexus of the lateral ventricle, either by the ultrafiltration of the plasma or secretion of the ependymal cells of the ventricular lining. Then it passes from the lateral ventricles into the third ventricle through foramen of Monro and flows downwards into the fourth ventricle through aqueduct of Sylvius. Then enters the basis cisterns through foramen of Mezendae and foramen of Lusca. Then circulates into the subarachnoid space and absorbed in the subarachnoid villi and finally flows into the dural sinuses and to the venous circulation. This is the unidirectional flow of the CSF from the site where it is produced in the lateral ventricles and continuously flowing through the ventricular system, thereby entering into the cerebral space and absorbed into the arachnoid villi, then into the joral sinuses, most commonly superior sagittal sinus, ultimately entering into the venous circulation. There is another theory saying that CSF directly enters into the venous circulation through the perivascular sheaths from the ventricles into the joral sinuses. Okay, from there into the nostril through the cribriform fillet of the ethmoid bone. Right? Yes, whatever may be the direction of flow of CSF, it ultimately enters into the venous circulation. So as to continue the circulation of this fluid from the ventricles into the bloodstream. It is a dynamic flow, non-stoppable, continuously flowing from the ventricular system, then entering into the bloodstream. Okay, so nearly around 500 ml is formed in 24 hours. Okay, the content of the CSF in adults is 150 ml, that in the infants is 50 ml. That means total volume of the CSF, that is around 125 ml in adults, it is getting circulated 3 times in 24 hours. Okay, through this ventricular system. So it acts as the cushion for the nerve tissue, bathing the brain as well as the spinal cord. Okay. Disparity between the production and rate of absorption results in hydrocephalus. As a matter of fact, the contents in the cranial cavity, the volume of the contents is always constant. So the brain tissue, the blood, and the CSF. Okay. Increase in any of these contents results in the raised intracranial tension, because intracranial volume is constant and it is limited space. Any increase in the contents of the intracranial space, that is, say the blood volume or the CSF or the brain tissue, results in the raised intracranial tension. So much so the volume of CSF, when it is getting accumulated, results in hydrocephalus associated with raised intracranial tension and compression of the brain parenchyma, which again results in the pressure over the cerebral circulation. Okay, which in turn results in the damage to the nerve tissue and the sequelae. This is the blood supply to the brain and the draining of the CSF through the perivascular spaces, ultimately entering into the joral sinuses. You see the picture. These are the branches of the arteries that are supplying the brain. And at the choroid plexus, there is a production of CSF, okay, through the capillaries, and the CSF that is produced into the ventricles. There is another route of entering the joral sinuses, that is through the perivascular spaces here. Okay, ultimately entering into the subarachnoid space, then absorbed into the subarachnoid granulations, and ultimately going into the dural sinuses and into the venous circulation. This is how the internal jugular vein drains these sinuses, ultimately emptying into the superior vena cava. There is another route that CSF flows down the perivascular sheath, enters the quadriplug plate of the ethmoid bone, ultimately enters the nostrils. These are the various routes of journey of the CSF from the place where it is produced into the ventricles, ultimately getting absorbed into the dural sinuses. That means there is nearly two pathways of the cerebrospinal fluid circulation. One is the circulation theory, that is produced in the ventricles and goes through the ventricular system, ultimately enters the subarachnoid space, getting absorbed into the arachnoid granulations, then into the dural sinuses. There is another route of traveling of the CSF, that is through the perivascular spaces and ultimately getting absorbed into the dural sinuses. These are the two types of pathways that is described for the circulation of CSF. This picture shows the production of the CSF by the choroid plexus in the lateral ventricles, then enters the third ventricle through foramen of Monroe. From the third ventricle through aqueduct of Cilius, it goes into the fourth ventricle, and from there into the basal cisterns, then circulates into the subarachnoid space of the brain as well as the spinal cord, ultimately getting absorbed into the arachnoid granulations, finally into the dural sinuses, thereby into the venous circulation. So the pathological classification of the hydrocephalus has been touched upon in etiology, but to mention again, there is non-communicating secondary to the aqueductal stenosis, tumors, vein of gallon obstruction, communicating hydrocephalus, intraventricular or subarachnoid hemorrhage, meningitis, neurocysticercosis, and leukemic infiltrates. All these things are associated with the presence of macromolecules in the CSF fluid, thereby causing the increased volume across the osmotic gradient that results in the hydrocephalus. Hypersecretory is again a theory due to the papillomas of the choroid plexus. Genetic syndromes have been already touched. Normal pressure hydrocephalus in undervenity, and the acute hydrocephalus, which is a clinical emergency, is caused by intraventricular or subarachnoid hemorrhage. Clinical presentation. Well, coming to the clinical presentation depends upon the type of hydrocephalus and the ability of the progression and the age of the patient. Acute hydrocephalus, as I told you, it is a medical emergency. It may result in the sudden rise in the intracranial pressure, complicating tentorial herniation of the temporal lobe, herniation of the cerebellum and brainstem through the foramen magnum, and the patient goes into coma and the pupils are non-reactive, may result in death unless treated. Congenital hydrocephalus. Newborn is delivered with large head, wide and tense anterior fontanelle, sutural separation, feeding difficulties. You see the scalp, it is shiny with prominent veins, stiff legs and arms because of hypertonicity, setting sign, setting sun eyeballs due to the downward pushing of the eyeballs, and the cracked parts sound are Messivian sign. Look at this picture. There is a large head with prominent scalp veins rolling down of the eyeballs, giving the setting sun appearance. This is the infant with congenital hydrocephalus. Well, when the child grows, there will be headache, irritability, poor school performance, visual disturbances secondary to the papilledema or extraocular muscle paralysis like the lateral rectus palsy due to injury to the sixth nerve. It is false localizing sign. It occurs secondary to the what to call traction injury to the sixth nerve as the brain tissue is pushed down due to raised intracranial pressure. And there is progressive motor dysfunction with the pyramidal signs and loss of balance. Coming to acquired hydrocephalus, there will be symptoms of severe headache, associated vomiting, visual disturbances, diplopia, patient may present with seizures, and there is progressive gait disturbance with loss of balance, pyramidal signs with stiffness of the extremities and loss of memory. Coming to normal pressure hydrocephalus. Classically presents with triad, Hakim's triad, that is urinary incontinence, loss of balance, and dementia. The loss of balance is due to broad-based gait, due to weakness of the lower limbs. Later, the patient develops gait apraxia. Gait apraxia. That means he does not know how to walk. Then there could be hypertonia with hyperreflexia, reflexia. Babinski is normal. As the condition progresses, he develops frontal lobe release signs like sucking and grasp reflex. So this is the spectrum of presentation of the hydrocephalus, depending upon the cause and clinical features at different ages of onset. Then coming to the evaluation, genetic testing and counseling for congenital hydrocephalus. Well, CSF analysis to exclude mold infection or any residual infection. Then X-ray skull. In the availability of the advanced imaging techniques, X-ray skull has got less importance. But anyway, X-ray skull, if it's done, you can find the erosion of the clinoid process of the pituitary fossa, and there is widening of the pituitary fossa. In addition to that, you will find copper beaten appearance of the skull bone. Then going to the CT scan of the brain, there is increased ventricular size in acute hydrocephalus. You sometimes find the ballooning of the anterior horn of the lateral ventricles, giving Mickey Mouse sign, commonly seen in hydrocephalus secondary to acute stenosis. MRI is a better option to differentiate the cause of hydrocephalus. Look at the CT scan of the brain, showing the Mickey Mouse appearance. This is the Evans ratio. This is the Mickey Mouse appearance, secondary to the ballooning of the frontal horn and that of the third ventricle. Temporal horns are more than 2 mm in size. Yeah. This picture also shows ballooning of the frontal and third ventricles, Mickey Mouse appearance. This is the X-ray skull showing the copper beaten appearance and widening of the pituitary fossa. It's a classical X-ray of the skull showing the copper beaten appearance and erosion of the cleanoid processes. The second one, the CT with enlarged ventricles. Then, what are the steps of management? Well, untreated patient may develop progressive brain damage and death. So, mainstay of treatment is the shunt surgeries. Commonly performed is the ventriculoperitoneal shunt. So, from the lateral ventricle into the peritoneal cavity. There are other procedures like ventricular ventriculopleural, sometimes ventriculostomy are done. Acute hydrocephalus, ventricular tap through the fontanelle or CSF drained by the craniotomy. Lumbar puncture in case of meningitis, acetazolamide is given to reduce the secretion of CSF by the choroidal plexus, usually given in pseudotumor cerebri. A brief touch on the prognosis. And prognosis depends upon the severity of the hydrocephalus. More severe the hydrocephalus, newborn develop brain damage and permanent neurological deficit. Less severe hydrocephalus, timely intervention, survival is normal with normal lifestyle. Then few little touch on the progression and surgical complications. So when the hydrocephalus is left untreated, patient develop visual changes, cognitive dysfunction, urinary incontinence, gauge disturbances, electrolyte disturbance, and metabolic acidosis. Well, following surgery, he may develop shunt infection, like there could be problems of undershunting or overshunting, trauma resulting in the subdural hematoma, and peritonitis, septicemia, seizures, okay, ascites, endocarditis, and pulmonary hypertension are some of the complications following surgery. If appropriate post-operative precautions and the regular follow-up is carried out, you can prevent the post-surgical complications and the patient lead a normal life with no morbidity or mortality. This picture again shows where the CSF is produced and the circulation. This is again the circulation of the CSF into the neurosinuses through the perivascular spaces. Well, this is the brief talk on the hydrocephalus. We have touched the definition of hydrocephalus as the excessive fluid, which becomes symptomatic. Okay, the symptomatic presence of the excessive CSF fluid in the ventricular system, having different causes, different pathological types like the obstructive hydrocephalus, communicating hydrocephalus, okay, normal pressure hydrocephalus, acute hydrocephalus, genetic syndromes leading on to the hydrocephalus, and the symptomatic presentation depending upon the age of onset of this particular condition. And unless treated, there could be progressive brain damage resulting in the mental as well as the physical handicaps, ultimately death. Okay, these can be prevented by the appropriate treatment and follow-up so that the patient can lead a normal life. Well, early identification of the pa- identification for hydrocephalus is very important in order to prevent the damage to the nervous tissue. And adequate treatment and follow-up in terms of the shunt surgery helps the patient to lead the normal life. Thank you very much for patient listening. We'll meet you again in the next class. Until that time, bye-bye. Thank you.